Welcome back. So now we are at the point in the case when Joe is returning. So let's turn back the clock just a few weeks. And we talked a lot about the various drugs that might be used in Joe's case. And by now you've probably figured out that according to the guidelines, he might be a person who would be prescribed a combination drug such as lisinopril and hydrochlorothiazide, or of course preferably some chlorthalidone and perhaps some lisinopril being two great choices for him. So say we went ahead and prescribed chlorthalidone at 12.5 milligrams, which is kind of a starting dose for that drug. That's taken once daily. And then we prescribed some lisinopril and went with 5 milligrams to be taken once daily. And in that case, since it's not available as a combination, we would have prescribed two different medications. In other words, he would have two separate prescriptions. Now, we could have also, per my prior comments, had him start one drug first, maybe the chlorthalidone, and he could make sure that he wasn't having any untoward side effects, and then start the second drug if his blood pressure still was high. As we've said before, chances are very good that he would be on two agents to start, or at least early in his therapy. And despite the fact that the guidelines tend to be pretty aggressive in terms of saying, hey, just start with the two drugs, if you have the opportunity for the patient to be checked in a few weeks, I think it's perfectly reasonable to do one at a time. He didn't get the blood pressure yesterday. It's not an overnight thing. And so again, we want to do the best we can for him in all ways. So he comes back and he returns for follow-up as instructed. His blood pressure today is 140/90. So still not quite to target. We want 130/80 for all populations. And he's been unable to quit smoking or drinking beer, but he has cut down. We don't know what that really means. He's lost 3 pounds and is walking 1 mile after work each evening. And we'll talk in a minute about some of the effects of those non-pharmacologic things. In this case, even while we will, of course, continue to work on his non-pharmacologic steps, pharmacologically, what would our next step be? And again, we go through our thinking of rationale, mechanism of action, and effect on the blood pressure equation. Now, we could add another agent, but I think it's a bit early in that his dosing for those two medications is at the low end of the range. For the lisinopril, he certainly can go up as high as 40 milligrams safely, and for the chlorthalidone, according to Hippocrates, he can go up fairly high, although most of the time we do a dose between 12.5 and 25 milligrams. So he certainly could double up and go up to 25 milligrams on the chlorthalidone, and he can go up on the lisinopril. If because of cost he had ended up on hydrochlorothiazide as his diuretic, I just want to make a note that in fact, the dosing is actually same numbers. We start with 12.5 for a person of his age and can go up to 25. If he was an elder, we might start at 6.25 with really tiny dose, start very low. But in his case, probably we'd start at 12.5 or 25. And even though you can go up to 50 milligrams, and you'll see some providers do, there isn't a lot of evidence to support that there's any real change in the blood pressure management after 25 milligrams of hydrochlorothiazide. So you're going to see that dosed probably at the 25 milligram level. And again, there are $4 pills that combine lisinopril at various doses with hydrochlorothiazide, 25 milligrams. So that's probably where he's going to land unless he has better coverage, or he isn't worried about expenses, because these things, of course, add up. Now let's talk a little bit about the non-pharm, and these are also prescriptions. I ask people to write prescriptions for patients for nutrition prescriptions, for activity, and so this is just some nice data to support the idea of the various diets, and of course the DASH diet, as well as the reduction of sodium, having a fairly good effect upon reducing hypertension, as well as getting more potassium. Again, being very careful, of course, in our patients with renal failure. They don't want more potassium. They have too much already. But for the healthy population. Body weight, and you can expect about 1 millimeter of mercury for every kilogram, or 2.2 pounds reduction in body weight. And so for a lot heavier person, you might get some very successful results with just weight loss. Of course, that's easier said than done. Now, physical activity, again, aerobic tends to be the best bet, but even some of the other activities, such as dynamic and isometric resistance. Now, reducing or moderating alcohol consumption, of course, can change blood pressure over time. And again, the recommended amounts of alcohol are 2 drinks for men, 1 drink for women daily. I also will note, of course, that tobacco use needs to be stopped, and that is more of the long term in terms of peripheral vascular resistance. Now, from just some notes from some lectures I've attended over the years, just in terms of your mechanisms of action, thiazides decrease blood pressure modestly via a decrease in peripheral vascular resistance. They do tend to worsen insulin resistance, but they also preserve calcium, especially the chlorthalidone. And this is nice for osteopenic patients, so it might be a little 2-for-1 medication. Beta blockade, again, we don't really use those as much for primary hypertension, except for people who already have cardiovascular disease. They do worsen insulin resistance, but we don't avoid them. And neither do we avoid the thiazides in diabetics. So we wean slowly on the beta blockers to avoid an abrupt increase in the adrenaline. They, of course, decrease heart rate and stroke volume. The alpha-1 combination, this is a very nice drug, kind of works on all 3. It's a twice-daily drug, but it's cheap. It's an alpha-1 beta blocker. It does increase insulin sensitivity a little bit, which is kind of a nice thing. So carvedilol is one you'll see quite a bit out there with our cardiac patients who are on secondary prophylaxis. ACEs we already talked about, or ARBs, not both, and they decrease the peripheral vascular resistance, and we talked about that in terms of the angiotensin-renin system. We do have caution for people who have bilateral renal artery stenosis. This is in young patients with secondary hypertension. And yet they are renal protective until the patient is hyperkalemic. And of course, these patients are referred to specialists for management. ARB can be your ACE alternative, as we've said, and sometimes they don't cough as much with the ARB or at all. There are some reports of cough with ARB, but the ACEs are the real culprits with the ACE-induced cough, rather. The direct renin inhibitors decrease peripheral vascular resistance. We've already talked about that. They are very expensive. We're talking close to $100 a month on those if they don't have insurance. Calcium channel blockers, they are most potent. They can cause the amlodipine and such, cause the swollen ankles, treat with TEDs, no meds. We already said this. the other class that like diltiazem, they are renal protective, but they're very potent CYP450 inhibitors. So you have to be very careful about interactions. And of course, a lot of these patients are on a lot of medications. For other drug classes that are out there are aldosterone. We already talked about that, the potassium sparing. They reduce peripheral vascular resistance. They can cause gynecomastia in the long term and in men. So we tend to stay away from those, although you'll see them used in heart failure. We'll talk about that later. And then alpha blockers, which are the ones with the azoxystrobin, those are used in benign prostatic hypertrophy. So my expression here, 2 minutes in one, we can sometimes get a little bit of help on their blood pressure as well, although the doses you need for blood pressure are fairly high and the doses for BPH are fairly low. So the only caution I would say about this is if you put an elder person on an alpha blocker for their BPH, you want to watch their blood pressure because they may drop a little bit lower than they want to and cause dizziness and fainting and falls. There are centrally acting older drugs that reduce peripheral vascular resistance. We do not use this as much, and aldosterone we use in pregnancy some. And then the sedating drugs, clonidine sometimes is used for anxiety as well as, I think someone mentioned in class, ADHD. So I'm going to end this section here, and this kind of concludes the hypertension discussion. Thank you.